So, David, congratulations
On what?
on completing your home reno project. I know you're excited about that.
Oh, yes. I can say I'm one of the few people I know who's done home renovations and actually had them go beautifully and actually had them be completed ahead of schedule.
So, not only were they completed ahead of schedule, were they completed on budget?
Let's not talk about budgets. We're going to be into some serious money area in the Medicare program today. So there's a lot. There's like budgets. My budget is nothing compared to what we're looking at in the kidney care space.
So you anticipated the segue perfectly, which is the renovations were taking place. I know you've been incredibly busy working on responses to a number of proposals from the federal government. How do you want to sort of walk through these?
Well, there's a couple ways to approach it, but I think the thing that our listeners need to remember is that when things slow down on the legislative side, and there's with divided government, there's going to be slowdown, and there is. That's when the regulatory pace picks up, because that's when the people who are in the White House want to make as much change as they can, and this is the area in which they can do it on the regulatory side. So that's really what we're seeing. We're seeing them, and we're seeing a lot of things that need to be dealt with. Plus, and we'll be coming back to our listeners soon, they're also preparing for what happens when the public health emergency ends. But for now, we've had explosive growth in Medicare Advantage, and that's also pushing a lot of this activity.
Am I remembering correctly that about 45% of the people in the Medicare ESRD program have now joined Medicare Advantage?
You are remembering correctly. I don't know whether the number splits out particularly by which providers to 40 to 50%, but it's about 45%. But the catch is it's expected during this year to surpass 50%, no problem. So there's been a massive influx. And you remember, we only started allowing incident kidney failure patients in January 1, 2021. So this has happened very fast.
So let's start with the first response.
Well, that goes to exactly what we're talking about, because the first one actually deals with technical changes in the Medicare Advantage program. And it may not seem like, these things sound a little bit like, small around the edges things, but they're not. When you just pointed out, so many people are going into those programs. So one of the things that we have been seeing is we basically have been seeing prior authorization requirements around dialysis, and also just kind of other issues around getting to dialysis through Medicare Advantage. And as you can imagine, ASN members and its leadership, there's nothing about kidney failure that should be requiring prior authorization. Once you've been diagnosed with kidney failure, your dialysis, if you don't have a transplant, is mandatory and obligatory in order to stay alive. That's all there is to it. So putting the prior auth on some of these things is just kind of a bridge too far in the Medicare program. So that was really the big change on that one, was making sure that patients did have access to dialysis and dialysis-related providers. They weren't burdened with prior authorization on dialysis, and that was the real focus of the first one. In a few minutes, we'll get back to the fact that they're doing the technical side to that, which has to do with interoperability. But if you don't mind, I'm going to move on to the second one.
Before you move to the second one, just a really quick question. So what was if I were sitting in Baltimore and I'm on Security Avenue and I'm working at CMS, why would I make this proposal? Like, why? It sort of begs logic.
Well, I mean, sometimes when they're sitting in CMS, they have to react to something that's happening that they didn't necessarily anticipate, or they didn't think would be at this level of activity. And I think that probably the number of issues arising from this became much larger than they wanted to ignore. So they were trying to get ahead of it because they could see the growth is not going to change. And prior authorization can really try up people's health care.
Yeah, and just to make a comment, and you don't need to respond, but because I know it's me sort of stating something I believe, which may or may not be true, and I don't have evidence. But I also worry that when we use the term end-stage renal disease, people don't realize that that's kidney failure. They think it's something different. I just think we have a real lexicon problem. But don't take the bait. Move to the second one.
I hear you completely. I won't take the bait. The second one is also something that I think our all of our members have had to deal with and they understand, which is the 2728 form, which is required if you're going to go into dialysis on Medicare. That form has been done by our listeners hundreds of times, and the Medicare decided it wanted to see if it could make some changes, but it did it kind of strangely. Rather than putting out a request for information, which they kind of said this was, that they already had put together their recommendations for what would be changed. And so, when ASN looked at this, within our committees that deal with these issues, we looked at it and was like, well, there's a lot here that you really have not dealt with. And I mean, I think we have the thought that there needs to be a more significant undertaking evaluating what should be into that form and what you're trying to collect with that form. And I think the number one cause would be the primary cause of renal failure questions that are on there. And so, our members really did talk about things like just nephrotic syndrome with or nephrotic syndrome with something else are somewhat vague, and they don't really get to what what should really be being used in terms of the way that we're gathering the information and what's being diagnosed. So the committees argued for a lot more structure, and the council agreed with them in terms of those diagnoses, in terms of the laboratory tests that might, but also things that were asked about transplants, so to speak, for example, which really has always been just a one box checkoff question. And they were trying to get to what a patient does understand at the time. And I think, a lot of our members are concerned that they may be trying to accomplish too many things with the 2728. And they were trying to register how much the patient understood of what was given to them. Of course, that's a very vague thing to try to measure in a form, particularly at a time when an individual is probably feeling quite overwhelmed. They may have just recently been diagnosed with kidney failure and probably just got out of the hospital, and now they're going into a system that's just asking them a ton of questions. And I'm not, there's some real concern that patients may not be in the best possible position to really absorb that information at that time. So there's a lot there. Both of these letters are fairly technical, and these are things that if anyone listening wants to contact policy at ASN, we'd be more than happy to send them copies of these letters. And even the next one, which I'm going to talk about, which is even bigger, which has to do with the United States Preventative Services Task Force.
Yes. Before we move to the third issue, I guess it's funny because on this one I can sort of understand why this is a harder one for CMS to get right, because there's not a lot of incentive to start with a blank piece of paper, but that's probably the best way to do this and to sort of have an iterative process where you're bringing together experts and starting to really design something. And what it sounds like they're trying to do is the proverbial, changing the tire on the moving car, which is hard. And then it just, as they start to flag issues, everything's more complicated than anyone could anticipate. Where do you see this sort of discussion going before we move to the third issue?
Well, it kind of goes into the bigger questions of the House of Medicine, because at the heart of what's being done with this in Medicare form is that CMS is trying to tie the whole classification system in with the ICD-10 code nomenclature. And that's really not what a practicing physician uses in their diagnosis as much. And so it's really trying to put things together that don't necessarily fit if you're on the front practicing. And that's I think would take a much bigger coming together of different groups, and that would take a lot more study by Medicare to try to adjust and try to get it sort it out in a way that I think everyone would be comfortable with it.
So let's move to the third one, which is former ASN past president Sue Quaggan's favorite acronym, USPSTF.
United States Preventative Services Task Force, which does make the recommendations on screening guidance throughout medicine and throughout healthcare. And after numerous years of asking for them to revisit their 2012 decision not to recommend kidney screening, they finally did put it on the list back last year. ASN and NKF in particular, along with others, have really been pushing for this for quite so many years. And they did put that back on. They put out a research plan, and everyone's very excited that they did that. And the research plan was open for evaluation, and the deadline for that evaluation comments was February 15th. And like many other groups, ASN did spend a fair amount of time trying to really kind of, bore down into what was in the research plan. And I'll say this, like I said, this is another one of those where if you contact us, we'd be happy to send you the letter. But I think probably the number one beginning concern that ASN had was the fact that the scope of evidence review clearly stated that they were not going to be using studies that had selected patients based on either diabetes or hypertension. And they were kind of making the assumption that diabetes and hypertension patients all automatically get kidney screening. And our members just feel like that just in practice is not correct. Some of the numbers show that probably only about 10% of hypertensive patients get kidney screening, and only 35 to 40% of diabetes patients get that screening, but that it's really kind of uneven. So that is in its very essence a concern that we have. We've been recently talking about, and Todd, we've been in some meetings talking about even the more narrowly defined, more rare forms of kidney disease. And we don't even get to that with this level of kind of analysis. So I think the biggest concern that we all had was that the plan was not robust enough, was that it was going to leave us with a situation where we would get kind of the same similar results that we had gotten in 2012. Primarily, we really just did not see kind of the evidence of the kind of pharmacological and non-pharmacological interventions that have moved so rapidly in the last decade or so. So to really take a big portion of this evidence to really look at SGLT2 inhibitors, other non-steroidal antagonists, glucagon-like peptide 1 receptor agonist. There's just a lot of that stuff that needs to be incorporated on a very robust level, because there's a lot of potential changes that can be heralded with these medications and these therapies that really were not available back in 2012. So what we were trying to do is advocate for something that really, is kind of the moment, of the science that really is there now. And the fact that maybe you don't want it to be all just about diabetic kidney disease or hypertensive, the hypertensive relationship to kidney disease. But the truth of the matter is you need to at least have those as a major component, because they do lead to the vast majority of kidney disease.
Yeah, and I would argue that part of the challenge here is that the U.S. Preventative Services Task Force, their approach here is indicative or highlights the fact that there's such little awareness and understanding of kidney diseases in general and kidney failure. And as a result, they make understandable assumptions which are just not correct. And then we're in this sort of vicious circle of, if there's not screening, there's not going to be increased awareness, and there's not going to be increased sort of diagnosis and treatment. And so this becomes sort of self-perpetuating, if you will. So it's a really interesting situation. And while exciting that there's a chance that they may reverse a previous decision, it's also hard not to be a little concerned that they may have scoped it so narrowly that this challenge may continue into the future.
I think that's exactly right. I think that's our job when we advocate on behalf of kidney diseases and kidney patients people with kidney diseases, and our members in their service of those patients. Because the fact of the matter is that if you do remain in that area where you just really don't have a good understanding of what kidney diseases are or what they represent. It's hard to kind of get that done. I'll say one thing, and I know we're wrapping up our time here, but one of the things that, really they don't do, and we're trying to get them to do this across the field of medicine, across the field of kidney care, which is they also look at harms and, will it harm people to be taking kidney screening? And, we're looking at this going, we're saying this in many parts of Medicare, which is you can't really compare harm if you are going to, unless you can include what the harm is to progression to kidney failure and to dialysis. Because you're making an assumption that things will remain good, they will remain relatively healthy, and yes, somebody at stage 2 or 3A, maybe they will, but there's a lot of people who are slipping through those cracks and ending up, like we said, crashing into dialysis, and that's the dynamic that we very much want to change. It's very inequitable how it's spread across, and it's very expensive. So the last word is, I think, for us on policy-wise, is we have got to fight that at every turn.
Yeah, and I'd mentioned ASN past president Sue Quaggan earlier in the podcast. If she were here, last year she published an editorial, and 2 points that she made. One was, not everyone. It's pretty amazing that the U.S. Preventive Services Task Force is assuming that the level of screening is occurring with people who are hypertensive and or have diabetes, because as we both know, that's not something that happens just in general in terms of the public. But then the other big issue is a point she's made, which I think it was former International Society of Nephrology President Nadir Levin had made, which is, shouldn't we be screening for kidney health, because this helps increase the pool of people potentially who could be living donors. And I do think sort of thinking about it from a kidney health perspective is a really interesting approach, and may help us as we sort of move forward.
I agree. I agree. And it's, we when you look around the globe, and particularly at some of the more successful single payer systems, and I'm not saying that we have to go to a single payer system, but I'm thinking of places like Japan, where, every year there's a series of batteries of tests that are designed to really evaluate the health of multiple systems within the body, regardless. And that's part of how they try to keep them managed, for long-term progression of diseases, and try to keep them limited, and really kind of stay more in the preventive phase than we do.
Well, David, thanks. It's been a busy beginning to the year, and just to highlight these 3 responses, and that they are available to anyone who would like to read them. But one really focused on the nexus between the Medicare ESRD program and Medicare Advantage. The second on potential revisions to the 2728 form. And the third, sort of responding to the U.S. Preventive Services Task Force and their sort of research agenda related to reconsidering screening for kidney diseases. I will give you the last word.
The last word is, I'm hopeful. We've got a lot of stuff happening here, and we're hopeful that we really can impact change, and really we seem to be at an inflection point. So I'm thinking on the positive side.
Well, David, thanks.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.